Check, check. Check, check. I was pretty close to the mic. 1, 2, 3, 4, 5. This is normal. Okay. Check, check, check.
today as we discuss problems with the Veterans Health Administration's sterile processing of reusable medical equipment, or RME. RME, items such as endoscopes, forceps, and other surgical equipment, is meant to be used repeatedly rather than discarded after a single use, and therefore must be re-sterilized between uses to prevent infection. These re-sterilization practices, which fall largely under the jurisdiction of VA sterile processing services, or SPS departments, must be both meticulous and timely to ensure that procedures occur safely and on schedule. Today you will hear a lot of discussion about inspection and reports. In simplest terms, VA medical centers are required to conduct annual self-inspections on their SPS departments and report the findings to VHA. Additionally, VISNs are required to conduct annual inspections of SPS departments within their network and report the findings up to VHA Central Office. On top of that, VHA Central Office must conduct triennial inspections of each medical center SPS department. If followed, this oversight procedure would help ensure SPS departments are operated safely. Based on issues we uncovered regarding VHA's sterile processing services, we requested that GAO conduct an audit to identify any systemic shortcomings. Unfortunately, GAO found VHA's processes for ensuring the safety and consistent sterilization of RME to be sorely lacking. The findings in this report represent a collision of several issues this committee has tracked throughout this 115th Congress. Of course, the report describes ongoing issues with sterile processing and workforce management, two challenges that the VA routinely battles. But an examination of root causes reveals another familiar theme: breakdowns in enterprise governance, particularly at the network and central office level. They create the opportunity for failures in safety protocols to go unnoticed or uncorrected. It is troubling to learn that VISNs were not consistently conducting annual inspections of their medical centers' SPS departments, meaning that networks don't know if their medical centers are training their employees, conducting quality checks, or otherwise running their sterile processing departments in an appropriate manner. But what is equally concerning is the fact that VHA's central office apparently had no idea that some VISNs were failing to submit SPS inspection reports to central office, suggesting that blame goes all the way to the top. Specifically, GAO's report explains how VHA officials were not even aware that they had not received all of these inspection reports until we requested this audit and GAO started asking questions. To explain a little further, GAO found that over 1/4 of the expected 144 reports were never submitted. In some of these cases, GAO found that networks had conducted reviews, but just never bothered to submit reports to VHA Central Office. When one network office was asked why they failed to turn in reports, they, quote, told GAO that they see no value in submitting them, end quote. To that point, VHA officials admitted that they seldom share information like SPS trends or best practices with the field, leaving medical centers and networks unaware how they compare to other programs and what areas there is room for them to improve. If VHA pays this information little attention and the field has no access to it, then clearly the established mechanisms for collecting and disseminating data fail to serve VA employees, or most importantly, veterans. The current governance structure is simply not getting the job done. The committee has raised this issue several times this year, including an entire hearing dedicated to VHA governance in general and the role of VISNs in particular. Central to that hearing and to this one today is the hospital that became the poster child for many of these issues, the Washington, D.C. Medical Center. Since the OIG's reports and our May hearing, we found out last month that the DC VA Medical Center performed so poorly this past quarter that its status has been downgraded from high risk to critical. So VHA Central Office will become even more hands-on in their attempt to rehabilitate the hospital. It is also still without a permanent director. The SPS issues we will discuss today are the tip of an expansive iceberg of governance issues continuing to prevent VA medical centers from consistently delivering high-quality health care in a timely manner. I look forward today to not only discussing solutions to RME-related issues, but also continuing our conversation regarding the broader root problems that continue to dog the system as a whole. With that, I yield to Ranking Member Custer for any introductory comments she may have.
Thank you, Chairman Bergman, for holding this hearing, and thank you to our witnesses on the panel, particularly GAO and IG, who continue to investigate and study sterile processing of medical equipment and medical supply chain concerns. It's important that these vital functions succeed because their failure, as we now know from too many incidents, put patients at risk of harm. The result of GAO's latest report are troubling. Not only did GAO find that the VA lacked reasonable assurance its medical centers were following policies intended to provide clean, reusable medical equipment, but that these recent findings were similar to those reported in 2011. Worse, the IG found these same problems at the DC VA Medical Center, as referenced by the chair. And for those of you familiar with the many problems reported by the whistleblowers at Manchester, New Hampshire VA Medical Center, sterilization and facility maintenance issues contributed to patient access and quality of care problems there as well. This continued pattern of lax oversight and accountability over basic functions of a modern hospital is indicative of a systemic problem with the VHA, a problem that justifies VHA's listing as an agency of high risk. The sad reality is that the VA has been on GAO's high-risk list for years, and yet still the VA has failed to provide an action plan to improve operations. Nor has VA made significant progress in making obvious corrections to its poorly heated internal controls. GAO's report found 27% of inspections of the sterile processing services at VA medical facilities were not even reported to the National Sterile Processing Office in VA Central Office, or that the Central Office does not communicate inspection results to the VISNs or VA medical facilities so that they could address common deficiencies. Without this data, VA cannot know which of their facilities are experiencing problems to prevent incidents like those at the Manchester, New Hampshire VA. GAO found that VA has yet to study its nationwide workforce shortage within sterile processing services so that it can determine why some facilities are experiencing major problems due to understaffing. GAO found that facility infrastructure problems, especially in older facilities, were leading to inspection deficiencies, but it's unknown whether VA has the resources, let alone even a plan, or if they're working on a plan to address these issues, and I hope we will hear from you on that today. In May, this committee held a hearing that investigated a related issue, the failed implementation of the Real-Time Locating System, RTLS, a failure that contributed to problems at DC and a system intended to help manage and provide oversight and accountability of sterilization. I'm disappointed to see that VA's written testimony lacks a progress report on this $500 million system that is years overdue, and again, I hope that you will provide this committee with an update. Underlying all of these findings is a lack of planning, resources, and especially leadership throughout VHA to use the information it receives in inspections to correct deficiencies, identify issues, and, as the chair mentioned, disseminate best practices so that other medical facilities can take action. VHA must ensure that there is an adequate workforce to clean and process increasingly complex reusable medical equipment. To its credit, GAO found that the VA has the organizational structure and processes in place to ensure medical equipment is sterilized and processed accordingly. And we also know that providers, such as the doctors and nurses and frontline healthcare staff who care for our veterans, have often gone above and beyond to overcome supply chain failures and that lack of leadership so that veterans will receive quality care. The importance of good leadership and the willingness to reform processes at the facility level is crucial for VA successes. I'm pleased to report that after new leadership was installed at the Manchester facility, they acted to resolve issues around sterile processing. Recent reviews by the Joint Commission have identified their reformed practices and procedures as a quote-unquote best practice that the VA should use nationally. And I would invite the VA to come up and meet with Mr. Al Montoya and to review what changes were made. These are the actions that VA needs, and I hope the VA can take the initiative and disseminate these practices across the country. What the VA needs, once again, is good leaders and sufficient resources to ensure that processes are followed so that our veterans receive the highest quality and timely care. I hope from this hearing we can get a commitment from the VA to devote resources to staff and facility infrastructure to address logistics and sterile processing challenges and to ensure that every VA facility inspection leads to corrective action to address issues threatening the health and well-being of our veterans. Thank you, Mr. Chairman, and I yield back.
Thank you, Ranking Member Custer. I now welcome the members of our first and only panel who are seated at the witness table. With us today from VA, we have Dr. Teresa Boyd, Assistant Deputy Undersecretary for Health for Clinical Operations. She is accompanied by Dr. Beth Taylor, Deputy Assistant Deputy Undersecretary for Health for Clinical Operations. Also on the panel, we have Ms. Sharon Silas, Acting Director of the Healthcare Team for the Government Accountability Office. Finally, from the VA Office of Inspector General, we have Dr. John Day, the Assistant Inspector General for Healthcare Inspections. I ask the witnesses to please stand and raise your right hand. Do you solemnly swear, under penalty of perjury, that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you. And let the record reflect that all witnesses have answered in the affirmative. Dr. Boyd, you are now recognized for 5 minutes.
Thank you. Good morning, Chairman Bergman, Ranking Member Custer, and members of the subcommittee. I appreciate this opportunity to discuss the Department of Veterans Affairs Sterile Processing Services programs with respect to reusable medical equipment, or RME. I am accompanied today by Dr. Beth Taylor, Deputy Assistant Deputy Undersecretary for Health for Clinical Operations, and a former Chief Nurse Executive with oversight responsibilities of SPS at a VA medical center. VHA operates one of the largest healthcare delivery systems in the nation, serving over 9 million veterans, one of whom is my stepson, who recently transitioned from active duty Navy. In providing healthcare services to veterans, VA medical centers use RME, which must be reprocessed between uses. Due to the increasing complexity of design and components, reprocessing has become much more complicated and time-consuming. Improper reprocessing creates potential risks such as infection and can adversely affect timely access to care, such as delayed or canceled surgeries due to the lack of properly reprocessed RME. Understanding that a successful SPS program involves many services at a facility, a group of stakeholders came together earlier this year to address the top trended challenges reported in our SPS programs. These challenges were identified through internal audits at all levels of the organization, as well as via issue briefs, an internal communication that I have come to embrace and welcome. We identified 4 major areas to work on. Workforce, including conversion of the sterile processing occupation to Title 38 hybrid, streamlining contracting and procurement processes, improvement of reporting and auditing, and addressing repairs and coordination of such within our aging infrastructures. SPS is dedicated to sustainable corrective actions and is achieved through improved communication, focused education and training, as well as commitment to collaborative policy changes with key stakeholders. In the GAO draft report issued in June 2018, there were 3 recommendations to the Undersecretary for Health, which are detailed in my written testimony, all of which VHA fully concurs. We appreciate the GAO report and found it validating as their recommendations correspond with our aggressive actions undertaken prior to the draft report. We are strongly committed to developing long-term solutions that mitigate risk and improve quality and safety of the VA healthcare system. Central to the success of SPS operations in the field is a solid and strong workforce. It is imperative that we have not only trained and experienced frontline staff, but also solid leadership in every SPS program. We know all too well the risk that leadership turnover poses on any program, including the oversight and management of this very complex and vital one. And we continue to address the need to not only hire and train frontline staff, but retain them. SPS programs have significantly improved the efficiency and safety of healthcare of our veterans as well as non-veterans, as exemplified in recent cases of factory vendor deficits noted by VA staff and who are now working with industry for universal changes. Patient safety and infection control will be improved because surgical instruments are being reprocessed correctly. As a physician, as a VA leader, and as the mother of a Navy veteran who receives his care at the DC VA Medical Center, I am confident in our ability as a learning organization to become one of high reliability. To sustain these efforts, we look forward to working with Congress, the GAO, and OIG as we collaborate to modernize VA. It's critical that we continue this current momentum and preserve the gains made thus far. Congressional support is essential to providing care for veterans and their families and is greatly appreciated. Mr. Chairman, this concludes my testimony. My colleague and I are prepared to answer any questions.
Thank you, Dr. Boyd. Ms. Silas, you are now recognized for 5 minutes.
Thank you. Chairman Bergman, Ranking Member Custer, and members of the subcommittee, thank you for the opportunity to be here today to discuss our recently issued report on the oversight of VA medical centers' processing of reusable medical equipment. The VA has a responsibility to ensure that veterans are receiving safe and timely access to care. Improper processing of reusable medical equipment can pose extreme risks to veterans' health, potentially exposing patients to infections or leading to delays in care if equipment are not readily available for medical procedures. VA medical centers use reusable medical equipment for a variety of procedures. This type of equipment can be used daily, often multiple times, and range from simple medical instruments such as surgical scalpels to more complex medical devices such as camera-bearing endoscopes. Historically, the Veterans Health Administration has encountered problems ensuring that medical equipment has been properly processed. For example, in 2009, the VA notified nearly 10,000 veterans that they may have been exposed to various infections due to endoscopes that were improperly processed at VA medical centers. Since then, both GAO and the VA OIG have reported numerous times on these challenges, highlighting the need for better sterile processing practices and guidance and more effective training for VA sterile processing staff. The Veterans Health Administration has tools to help ensure medical centers adhere to policies and requirements. For example, each year VA's regional offices or VISNs use a standardized inspection checklist to review medical centers' sterile processing programs. There are also issue briefs generated when a medical center is involved in a significant safety incident that affects a group or a cohort of veterans. We examined the Veterans Health Administration's oversight of VA medical centers' processing of reusable medical equipment and found that the VA central office did not have complete information on the visit inspections of the medical center sterile processing departments which are responsible for managing and conducting the processing of reusable medical equipment. Specifically, we found that for 144 visit inspections that were supposed to have been conducted in fiscal year 2017, the central office was missing 39 inspection reports. Further, we learned that in some instances, some of these inspections were not conducted at all. We also found that the central office does not analyze or share information on inspection results across the VA healthcare system due to a lack of resources. As a result, VA is missing on an opportunity to share lessons learned and best practices that could help mitigate potential problems across the VA healthcare system. And in fact, VA medical center staff we spoke with told us they would like information on inspection outcomes and trends and findings so they can better address processing challenges. Lastly, we identified areas where VA medical centers were experiencing challenges in processing reusable medical equipment. For example, sterile processing departments experience challenges hiring and retaining qualified staff to properly manage and handle the processing of reusable medical equipment. These departments, like many others across VA, typically experience long time frames to hire qualified staff. We also heard that staff typically receive low pay and once on board often have to work overtime and have limited opportunities for job growth. Particularly as medical equipment continues to evolve and become more complex, it is even more important that VA has enough highly trained staff to process reusable medical equipment. Based on our findings, we recommended that VA should ensure that the annual visit inspections of VA medical centers' sterile processing programs are conducted and the findings reported to the central office, and that the results of these inspections be shared across the VA healthcare system to help all programs improve. Lastly, VA should study sterile processing workforce needs to ensure medical centers have enough qualified staff to effectively reprocess medical equipment. In short, although the Veterans Health Administration has taken steps in the last few years to improve their oversight of reusable medical equipment, such as developing new guidance and policies, we found there are still some areas of improvement needed to ensure veterans continue to receive safe and timely access to health care. This concludes my opening remarks. Thank you.
Thank you, Ms. Silas. Dr. Day, you are now recognized for 5 minutes.
Thank you. Good morning, Chairman Bergman, Ranking Member Custer, Chairman Rowe, members of the committee. It's an honor to be asked to testify before this committee today. I think it's fairly straightforward to understand the functions of sterile processing, logistics, and human resources at a VA hospital. The OIG report on the critical deficiencies at the DC VA highlights the fact that the risk of clinical error and therefore harm to patients increases when these business functions do not operate successfully. In addition, the poor performance by these functions increases the cost of VA healthcare. The OIG reports in the current GAO report identify VA organizational structure, in my view, as an impediment to the efficient operation of these business functions by presenting confusing lines of authority. The current administrative alignment of VA, in my view, is outdated. It was created before the widespread use of email, before the prevalence of large data systems, and it is, I think, time to consider changes to the organizational structure of VHA's VISN system. With respect to SPS controls, VA currently places too much risk prevention strategy upon the shoulders of the bedside clinician to recognize and react to problems when the equipment they are provided may in some way be defective, that is, at the point of care. Having said that, this conversation is mostly about the risk of harm to veterans. I am not infrequently called and asked to comment on why a facility closed their operating room or chose to limit certain procedures. And when I call VHA leadership, invariably I get a wonderfully responsive, appropriate answer indicating that there was found some defect in SPS processing or other defect, and they've taken the exact correct step in the interest to not harm veterans. I would be pleased to answer any of your questions. Thank you.
Thank you, Dr. Day. I now yield to Ranking Member Custer. Do you want to go ahead and do your questions first?
I would be happy to.
All right.
Thank you very much. Thank you, Mr. Chairman, and thank you to our panel for being with us today. I wanted to focus in, and hopefully our VA witness will have a plan in place about this, but what is being done to hold senior leaders at VA medical facilities, VISNs, and VHA accountable for the management failures within the facility's sterile processing services? And is there a plan for improvement and particularly for sharing best practices?
So the first question about accountability, this came up in multiple conversations, as I mentioned earlier, when a group got together and looking at the world of SPS and the failures and the weaknesses and gaps that we needed to address. And you mentioned, I think earlier as well, about VH governance and some of the modernization as well. What we found is that, and there's no excuse for it, there have not been very codified, clear roles and responsibilities at all levels of the organization. Coming in new to this role, and as many of us did, and coming from the field, this is an improvement that must occur. So we are working on those roles and responsibilities at all levels. So everybody knows what the expectation is, what they're accountable for. And this goes all the way down to the chief nurse exec within a facility who actually reports and works hand in hand with the medical center director, all the way on up through the VISN with the quality management or the chief nurse at a VISN level, all the way on up to my level as well. So,
Do you agree that, for example, in Manchester, New Hampshire, surgeries had to be stopped because there was, the quote that I read, rust or blood on the surgical instruments? Does that threaten the quality of care for veterans and even access to care if surgeries have to be canceled?
So twofold. It's important that we, like Dr. Day mentioned, that we actually welcome staff stopping the line when they find things like that. Now, that being said, if there is a trend on that, if it's not a one-off, then we need to really look for further and deeper and move it to the left and say what happened along the way that we're getting this in a trended
Well, even if
fashion.
it's a one-off, what's the process of, is there an investigation when that happens? And I mean, I guess what I want to hear from you is some urgency in tackling this, because another example, there were 10,000 veterans notified of potential hepatitis infection. I mean, this seems to me urgent in terms of our interest in caring for our veterans.
So you mentioned that the 10,000 back in 2009. There's a tremendous sense of urgency at that point, and that's when SPS changed from purely an administrative, non-clinical logistics type function in a program very rapidly into a clinical, the clinical nurse exec at the field. And that's when we realized we needed SOPs, standard operating procedures in place, manufacturer instructions, and to use those. And so there was a huge sense of urgency back in 2009. I hope
You
that
feel like that's lost now?
I do not feel that that's lost, Ranking Member Custer. What we have in place, though, what we're finding now are I would hope, the one-offs, and if it is a one-off, it's still a problem. We need to stop and figure out what happened along the way. Was there a competency issue? Were the SOPs not in place for that particular frontline staff member? All along the way, we need to figure that out, because you're absolutely right.
Well, it seems like there's also a lack of staff. There's a shortage of staff, and that there's a long wait time to hire staff. Is anything being done to focus on that problem? I understand they enter as a GSA 5. That probably isn't drawing the quality of the staff that you need in these roles.
You're absolutely correct. And one of the major changes that has recently occurred is that we finally have changed the occupation series from a strict Title V to a Title 38 hybrid, which gives us pay flexibility. It will also, this is fairly new, so we finally got that. And so this will change the grades as well. Now, that's not everything. We still have the assistant chief and chiefs with which to deal with, but it does address our authorities at the front line for these folks. You're absolutely right.
So my time is up. I yield back.
Thank you. Chairman Rowe, you are recognized for 5 minutes, sir.
Thank you, Mr. Chairman. And I want to say that I find it amazing that we're even having this meeting today. I mean, it's astonishing to me. Koch's postulates, which the three of you I know for sure know what that are, is a germ theory of disease. It was published by Dr. Koch in 1890, so we've known what that is. The most basic function that's performed in the hospital, and I know three of you all have been in operating rooms, in patients' rooms, is to make sure that you have sterile equipment in which to operate and take care of those patients. That is the most basic thing we do in a hospital, and I find it absolutely amazing that we're having this hearing this morning, that we're even talking about it. Because I know when I went in the operating room, I've been there thousands of times, both as a primary surgeon, as an assistant surgeon, as a medical student, as a resident, and then as a professor teaching residents how to operate. I never even thought about, was the equipment going to be sterile that I'm using today? Every day before I went in the operating room, somebody from the surgical suite would come in and say, Dr. Rowe, we have, you're doing this tomorrow, we have your sutures pulled, we have all the equipment you need to do your surgery. I don't ever recall a case that was canceled because the equipment wasn't sterilized properly or that. If you're in a for-profit hospital system, as many people have here, if that information got out, that thousands of people potentially were harmed because of that, that hospital system probably would cease to exist because of lawsuits. And I still cannot imagine that we don't have procedures very basically about how we train people to sterilize equipment. I find it amazing. So I've been here now it's my 10th year here. If I'm fortunate enough and come back, am I going to continue to see stories in the paper about we haven't gotten, someone's going to the operating room? Because, your stepson may be going into the operating room, and I would want to think that young man would confidently go there thinking, I'm at a VA hospital and I'll be cared for properly here and that the equipment is sterilized. Can he go there with that assurance? That's my question. Can he?
I believe he can. And here is...
Well, believing is different than knowing that he can. I want to know
That's-
that he can go there and that the surgeons know that the equipment is sterile and that they can confidently know that when they take he or she veteran to the operating room or to wherever, to any procedure room, that equipment will be functioning and it will be sterile and that I don't have to even worry about that.
That's correct. And what I can say to that is this. When we look at surgical site infections, because I think that's a surrogate marker for poorly or inadequate operative arenas, the surgical site infection rate at the DCVA is 1.09%. The national rate is 1.41%. And the industry, most recent industry data is 1.9%. And this is in the operatories. This is a surgical site infection rate. I can also say that because of our culture of safety and our transparency, which we absolutely stress.
Let me back up, and
Okay.
we can argue about those things. The question I have, and obviously if you're in a trauma center, your infection rate's going to be higher than if you're doing all elective surgery.
That's true.
You got to compare apples to apples if you're doing sterile gallbladder laparoscopic cholecystectomies. That infection rate ought to be minimal. If you're doing gunshot wounds and trauma, open fractures, you're going to have a higher infection rate. So you got to know what you're comparing to.
Absolutely, sir, yes. Back to your question, though. Of the operations that we had on the books that were scheduled and that we actually performed in the VA in the past year, we had over 424,000 surgeries performed. And our cancellation rate was only 0.8% that was attributed to RME issues. And our staff report very quickly, which is a good thing, that they stop the line if there is an issue. So 0.8% of those cases were canceled due to RME.
Here, let me ask you very quickly, and I know my time's about expired, but basically, Dr. Boyd, what are you doing to address the key oversight breakdowns in the National Program Office for Sterile Processing? And then why were these issues not addressed after the 2011 GAO report and the IG report on the Washington, D.C. VA? And I'll leave that for later if we have a second round. I yield back.
Thank you. Mr. Peters, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thanks to the witnesses for being here. I did know that in San Diego that there's been a recent renovation of the sterile processing services facilities, but there's this issue that I think GAO, Ms. Silas, identified with respect to personnel. They have found that the SPS technician position was downgraded by the VA's classification unit. The local facility can't change the classification of that position. And then, as I think was mentioned, the hiring process is 3 to 4 months long. There's long hours, limited pay, limited promotion. So what programmatically is going to be the VA's response to this? Are we going to talk about changing the classification of the position? What would we do to make sure we get the right people taking care of this important task?
I think there's a couple things in response to your question. One, it's going to be one of our top priorities to address the workforce issues, because you're absolutely right. These are key to the success of any well-staffed, well-run SPS program. The downgrades occurred with regards to the SPS leadership roles, the chief and the assistant chief, not to the technicians. So we did have published guidance this summer that came out that transitioned them from a pure Title V to a hybrid 38, which Dr. Boyd mentioned. That we consider as step one. Step two is moving forward to look at those classifications of our leadership roles and ensure we have the right classifications, the right salaries to attract the quality and the skill sets required to run this very complex service.
So, Dr. Taylor, do you disagree with any of the things that Ms. Silas mentioned about the employment, the difficulty in hiring the right kind of employees? Do you generally agree with that?
I generally agree, yes, sir.
So you've talked about one reclassification. I think that's what you said just now that you did.
The classification of the SPS service, the downgrade was focused on the chief and assistant chief.
Right.
So that's going to be our priority going forward, is getting those classified at the level we think is commensurate to attract and retain the quality and skill set we need.
And have you made any specific conclusions about what you need to do to address this in terms of the level of salary or?
Yes, we have a workforce work group actually that has convened, started the work earlier this summer. We're requesting that they provide a due out by the end of December of this calendar year, focusing on that exact issue, sir.
Okay, to me, that seems like a lot of time for a pretty specific question that's been raised about one workplace employee. So I disappointed here it's December, but when do you anticipate you're going to make a recommendation on actually changing the conditions or the turnaround or the salaries so that we know we get the right people in these jobs?
Yeah, I think it's important for me to share that in the interim, we're also looking at the application of the pay authorities that we currently have and ensuring that the medical centers who have challenges or are in markets such as San Diego and greater Los Angeles, et cetera, that they're using those authorities in a way that they can retain the staff. For example, retention bonuses that were just implemented in greater Los Angeles for the technicians, not the chief or assistant chief, but at the technician level to make sure that we could retain those individuals. So that's really a priority for us, to dialogue with the human resource officers at the VISN and the local levels between now and the end of the year to ensure that we're using the authorities we have most
So
aggressively.
you're looking at the employment market VISN by VISN, so that's why it takes more time, is that what you're saying?
That's correct.
All right.
The employment market in greater Los Angeles is different than the employment market in Grand Junction, Colorado, for example.
Right. Okay. Well, and then after you get the report in December, do you have a sense for how long it will take you to make a recommendation? Or it doesn't seem like a very complicated thing to me.
I think we should have recommendations within the next 6 months.
All right, good. Well, I look forward to seeing you back at the committee, or
Yes, sir.
if the chairman wants to entertain it in writing, whatever, we'd be happy to hear what you do about this. Obviously, it's fun to hear Dr. Rowe talk about how basic this is. I think a lot of us lay people who are customers at hospitals, we worry about infections these days. Mm-hmm. And we know that the kinds of infections that we're susceptible to in hospitals are particularly pernicious. So I think it's certainly important for us to get in charge of this, and hope you take that seriously.
Absolutely.
Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Peters. Mr. Poliquin, you're recognized for 5 minutes.
Thank you, Mr. Chairman, very much. I appreciate it. Ms. Silas, you're involved with the GOA, right? GAO, whatever it is. I know what you folks do, generally speaking. Every 3 years, the VA Central here in D.C. is supposed to make sure that 150 or 60 different VA hospitals around the country submit a report such that the VA Central, thank you, is comfortable knowing that the hospitals in the field follow a procedure to make sure things are sterilized when they operate on our veterans. Is that right? Yes or no?
Well, there are actually a number of oversight tools that
Is VA Central due to investigate these folks every 3 years? Yes or no?
the visits and inspections happen annually.
Well, that was going there next, is that we have 18 visitors, which are the regional folks, right? Not VA Central here in D.C., but the regional folks, and they're supposed to get annual reports from the hospitals out there. Is that right?
Yes.
Okay, but if I understand this correctly, in 2017, 27% of the hospitals didn't even submit a report that they followed these protocols to make sure this equipment is sterile. Is that correct?
It was actually 27 reports had been submitted.
Okay, a bunch have not been, right? Okay, and then those that were submitted, I think anywhere from 20 to 40% did not adhere to the procedures that were outlined to keep this equipment sterile. Is that right?
Those are the 20, those were the,
Okay, I just heard, thank you. I just heard from Ms. Boyd, I think it was, that, or read somewhere also, that VA Central doesn't have enough resources to make this happen. Doesn't have enough resources. Let me remind everybody here that 10 years ago, the VA system had 230,000 employees. They now have 385,000 employees. And over the last 8 years, the budget's gone from roughly $80 or $90 billion to $187 billion per year. You think you can find someone there to do this right? How long has this been going on? Ms. Boyd, how long has this been going on? How long have we had a problem with making sure this equipment is sterile, which is so common sense, so our veterans who gave us our freedom, gave us our country, aren't impaired? How long has this been going on?
So if I could just make one just real clarification here.
Sure.
The reports that get rolled up, the audits and the oversight, the site visits that occur from a visit into a facility and then also our triennials, there are 160 some odd checkpoints on there, and it's everything from documentation of competencies to the humidity. I mean, all sorts of things. So not clearly that there's not following, and they're not ending up with safe equipment.
Yeah, I know. That was one of the things you folks said, that the clinics are so unique that a standard protocol doesn't fit every site. Doctor, do you believe that?
You think the standard protocols would apply to a piece of equipment across each site?
Yeah, I would think so too. Could you answer my question, Ms. Boyd, that I asked a minute ago? How long has this been going on? How long have you had a problem with this?
Your question again was how long have we had a problem with maintaining oversight?
No, making sure that the equipment is sterile at the hospitals such that our veterans are cared for properly, which means they've got to follow a procedure, right, that's dictated from Central or from the VISNs, and they clearly aren't doing that. How long has this been going on? All of it.
Okay, so we still have
a year, 2 years, 10 years, as long as you've been there? How long?
We do have opportunities to improve our process.
Forget the question because you're not going to answer it. Who is responsible? Who is responsible? I want the head person who's responsible at VA Central to make sure this equipment is sterile and folks in the field are following the protocols. Who's responsible? I want a name. Who is it, please?
We are, sir.
You are. Good. You too?
Mm-hmm. Yes, sir.
Wonderful. How long have you been there, each of you?
I came in April, sir.
April of this year?
Yes, sir.
And how long have you been there, Ms. Boyd?
I came in May.
In May. So you're new. So I can't point fingers at you because you're trying to fix the problem, right?
Yes, sir. And we both came from the field.
Great. Thank you very much, so I won't lose my patience with you. Is this getting better, or are you going to come before us a year from now and see we have the same problems, and these nice folks over at the GAO and over at Inspector General are going to say, no, they talked about it, they haven't fixed it. You going to fix this or not?
I would like to answer that.
Take your
yes,
time.
Sir.
Good.
Yes,
when?
Sir. We will be glad to come back here at the request of the chairman at any time and give you an update. We have multiple work groups. We have multiple actions in place thanks to the oversight that we get from OIG and GAO. They are our partners.
Before you came here, Ms. Boyd, who was responsible for this? Before you and Ms. Taylor came here?
So the person in this role was Dr. Lynch.
It was Dr. Lynch. Is he still at the VA?
No, sir. He is retired.
He's retired. Anybody else involved, or just Dr. Lynch? He was the person.
In the role that I took over in that role.
Did he retire, or was he asked to leave?
Oh, he retired.
He retired. Okay.
Yes, sir.
Keep doing what you're doing. We'll help you every way we can. Thank you very much.
Thank you.
Appreciate
Thank
that.
you, Mr. Chairman.
Thank you, Mr. Poliquin. By the way, we will have a second round, so, for those, because I think we may have some more questions, especially given the knowledge base of our panel here. So, Mr. Lamb, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Ms. Boyd, Ms. Taylor, I just wanted to ask about an incident at the Clarksburg VA in West Virginia involving spotting on some of the surgical instruments. Are you familiar with that episode? It happened in the last few years. Yeah. So when that happened, some of the veterans who were affected by it in terms of their appointments and procedures were sent up to the Pittsburgh VA, close to where I live in my district, and I believe they were treated there in some cases. And so I was curious, when that happens, I'm assuming it's probably happened in other places around the country where they notice a problem, they look to nearby VAs to cover the gap in the meantime. Is there a mechanism to make sure that the VA who's covering, in this case the Pittsburgh VA, gets additional resources or gets additional tools that they need to cover that new influx of patients? How is that handled?
That's a great question. I think typically the receiving VA will determine that they have the capacity to assume that additional workload, those additional patients, and so they will actually reach out and say, we can do this. So they may not receive any additional support because they have determined that they have the capacity to take.
So they basically volunteer if they're able to do it? Mm-hmm. Okay, thank you.
Yes, sir.
Ms. Silas, you mentioned in your testimony that at least part of the problem here was a shortage of employees, and I think you mentioned something about a lack of overtime pay for those who were remaining and who were working on some of these issues. Could you just elaborate on that a little bit more?
Certainly. I did note that there was an issue with overtime. It didn't speak specifically about the overtime pay.
Sure.
But it was something that we heard consistently across both our interviews with the visit officials and at the facility level, that staff were often asked to work overtime, and that could potentially result in issues with delays in processing the reusable medical equipment.
And can you just what is it exactly that you heard? Can you explain that to me? Because it sounds like if they're asking them to work overtime, someone's working on the problem. So what's the issue?
Yeah, that there was a number of vacancies, and so then they were asked to work overtime to fill for those vacancy spots. So there wasn't enough numbers of staff in the program itself to make sure that the equipment was being processed.
Okay. And Mr. Day, I just wanted to ask you to elaborate a little bit on your comments that you think the VA's administrative alignment is outdated these days. Can you talk a little bit about the cause and effect? Like, what's the cause of the failure to comply with sterile processing procedures from an administrative standpoint?
So it seems to me that an operating room's function is pretty basic to the operation of a hospital. And it seems to me that the staffing of SPS, sterile supply, staffing of logistics, the pre-check to make sure you have the equipment that Dr. Rose spoke of, should all occur every day, all the time, without any interruption. When we go to the VA hospital at DC, we found that a number of services that were business offices were critically understaffed. Something like, I'll have to make this up, but like half of the people in SPD were not on the books. A significant portion of the people in logistics were not on the books. So if you're running a hospital where the only metric you look at is infection rate, for example, that's a good metric to look at, but it doesn't speak to the business operation of what you're really trying to do. So the short answer is I think the director of a hospital ought to take whatever action is needed to make his operating room or her operating room run efficiently. And if you need SPD people, then you hire SPD people. If you need logistics people, you hire logistics people. And if you can't get it done, then you go up and talk to the next chain of level of command and say, I need help. And if they can't get it done, they come to you and say, I need help. So I think this particular problem, I think that at a national level, where they're going to buy software, for example, or whether they're going to have, government has certain standards about, classification of people, I think that's all a national issue. But the actual just making, juice out of oranges every day, that has to work well at the local level. So I have a very hard time understanding why these problems continue to exist. They do exist. If you go back to 2009, one of the more interesting features of the episode that we had where VA's colonoscopy equipment was not being properly reused or re-cleaned, the Undersecretary for Health sent out a directive to everyone in the field and said, we want you to do this. And it laid out an organizational structure and a few things they were supposed to do. We went out about 6 months later and checked to see if they'd done that. And people just really hadn't. One of the problems VA has is that healthcare is local. Well, local is great unless you're trying to provide a standard benefit that the government wants to provide to everyone in the country. You need people in small places to do what the Undersecretary of Health says every time. You have to see that. So your hospital is wired differently it has a different organizational chart than the hospital in Indianapolis, than the hospital in DC. So all of these lack of standards make it difficult for central office to communicate effectively with the field and get things done. So I think it's a system that really needs to be redesigned and thought through who should be responsible for this and that, and then given the right authorities and then allowed to do that. I find VISNs to be very ineffective every time I look to see what VISNs might do. Maybe, since I only get called to see problems, maybe they're doing things I'm not aware of. That's a possibility. But I don't find them to be, the savior at the end of the day to solve a problem or prevent something from happening.
Thank you, sir. We seem to hear that a lot as well. Mr. Chairman, thank you.
Thank you. We heard Dr. Rowe talk about what it's like to be the surgeon handling the instruments. My first career after 7 years of active in the Marine Corps was in the surgical instrument business. So let's talk about the end of the case. When the patient's already left the room, going out into recovery, and they're taking all the instrument trays, whether they be, they're going back for processing to go into an autoclave, whether they're going to go into a sterile soak, whatever they happen to be doing, but they're all going to leave that OR. They're going to probably go in a cart, whether it gets on an elevator, down a hallway, into central supply, central sterile supply. It used to be called a long time ago. The point is, how many, would anybody venture a guess at the table, how many of your medical center directors have ever spent any time in central supply, gloved up, understanding the difference between what it means to clean the box lock of a hemostat as opposed to the cannula around an optical head? I mean, would anybody want to venture a guess how many of your medical center directors know the details? Not that they're proficient in all of them, but they've actually hands-on observed or whatever it is.
Sir, speaking as a former nurse executive, I can share that all of the directors that I worked with would accompany me from time to time, whether it's on environment of care rounds, whether it's just rounding to visit.
Okay, so they know,
Yes.
they know how it works. So there's nobody sitting up in the corner office not having a clue how it works. So you're saying you're vouching for all your medical center directors that they know how things are supposed to go on in central supply.
The ones I worked with, yes, sir, they did.
Okay. So then what is it? What is it if you're the captain of that ship, if you will, you're the director of that medical center, and you know that to eliminate that infection rate because of the use of a dirty instrument is going to ensure better outcomes for your VA patients, why aren't the directors of the medical centers who have a sterile processing unit within their building confines, why are they not like a pit bull on your ankle when it comes to getting it right? Tell me why. Why not?
Well, sir, I'll speak to the directors that I have worked with, and they have been pit bulls, a few of them.
So then if what I hear, the vision is part of the problem, not part of the solution. So if I'm the medical center director, the vision is somewhere else in another city, I know I'm responsible for the outcome of my patients. What's inhibiting the medical center directors from just taking the bull by the horns and making sure that those standards are adhered to and those instruments are clean?
I'd like to make one point of clarification, because we've mentioned dirty instruments in the OR, and I believe it's important to make the distinction that between dirty instruments going to the OR and one step in one process for one piece of equipment or instrumentation is missed, and therefore we are not compliant with an SOP. I think how we are measured is if we're completely compliant with our standard operating procedures. In a 1A facility where I worked for the past couple of assignments, we had anywhere from 200 to 250 standard operating procedures, each of which may have up to 150 steps.
Okay, so have we got too many procedures? I mean, too many steps, too many compliance steps? Because you've got someone who actually physically has to handle that instrument.
Yes, sir.
Whether it be in an instrument tray or whether it be just a separate instrument as in an endoscope.
That's right.
So they're the ones that are ultimately, they're the hands-on, they're the eyeballs on, they have their procedures to check exactly if that instrument passes muster to go back into a sterile tray, then to go back into the sterilization process, then to go back into the OR. So what's inhibiting that? Do I hear you saying we have too many compliance?
No, I was attempting to put the non-compliance in context. It's simple, as was stated before, but simple doesn't equate to easy. And when you
But is someone training, if I'm the person, if I'm that new person that you just hired,
yes,
you're teaching me how to clean that instrument, and you're my supervisor, or you're that third-party training entity. Don't care, because companies who manufacture those instruments, they provide expertise to come in there and train the people, not only how to use the instrument in the OR, but also how to clean the instrument so it's ready to use again. So whoever's responsible for the training of that individual, I mean, are we missing something here?
I don't believe we're missing something. And to go back to a question that was asked a little bit earlier about the history, we, in 2009, when the issue was raised initially, or when we really had a lot of discussion about this, again, I was a nurse executive in the field, we had very few, if any, standard operating procedures. We had very little guidance. We did not have committee structures.
Hold on.
So we...
Hold on. Just hold on.
Sir.
VA medical centers aren't the only hospitals in the world.
Correct.
Okay, and there you could have, in my district, I have a Dickinson County Memorial Hospital, a county hospital, 4 blocks from the VA hospital. They do the same procedures in a lot of cases, and they're going to have 2 separate, central sterile processing departments. Are you saying that they're outside the VA system? There's not enough data, not enough standardization procedures that we can just take what's working in another hospital somewhere and just... Are we reinventing the wheel here?
I don't believe we're reinventing the wheel, sir, but I can say that our national office has actually been asked to consult with the Joint Commission as they review sterile processing services, not only within the VA, but also in the private sector, because they do believe that the approach that we have taken is the most thorough.
Well, you know what? When you have a veteran who's getting a procedure done today, and if they have to think that they're assuming risk, again, I'll use Iron Mountain, Michigan as the example, that they're assuming unnecessary risk by going to the Kingsford VA hospital as opposed to going to Dickinson County Hospital, that's shameful. It's the wrong thing, and if that's what we're saying in the VA, we have to do more paperwork and add more, divisions involved and all that, then we've totally missed the boat here. So you guys are the messengers. You know that every time we have one of these hearings, you come in here and you take the spears.
Yes, sir.
And the point is, we and all in this committee, doesn't make any difference which side you sit on, we want to make sure the veterans don't get infections because instruments aren't clean. So I will yield back. Mr. Peters, would you like to ask a second round of questions?
I just had one more question, which was an indirect question. So, and it has to do with facility maintenance issues, particularly in older facilities that lack proper ventilation. I know that this has been an issue with respect to infections as well. Do you have the resources at the VA to address the deficiency when they're identified during the inspection? And do you know how much is budgeted for VHA to address this problem?
So for the first part of that question, and it's a very good question, because one of the areas that we found early on this year was that we really needed to match up what goes on in the engineering portion in our infrastructure, in our facilities, the facilities management, because their activities, whether it be a regular maintenance or flushing pipes or changing steam traps or whatever, that affects SPS processes for that day. And so those two services need to talk. So very important, and especially within our infrastructures that are aging. The second part of your question, I am not aware of that information. I do not have that information, but it's something that we could get back to you on. It would be someone else that I'd have to ask about that budgetary line item.
Yeah, that would be very helpful. I appreciate that.
Absolutely.
And, I would yield back. Thank you, Mr. Chairman.
Sure.
Thank you. Dr. Rowe, you're recognized.
Thank you. Just a couple of questions. One, just to reassure people, most situations, people going to the operating room at a VA hospital is perfectly safe. I want people to understand that these are the outliers that we're talking about today. And I think Dr. Day hit it right on the nail, right on the head when he was talking about this really is a local issue. It's a local situation, not to a VISN or to the central office. This is a very basic operation of a hospital. And these procedures are there for a reason. They're to protect people. And sometimes they are, like you said, it doesn't make them simple. These can be very complex things to do, but they're there for a reason. And they're there for patient safety. And so I think the responsibility lies absolutely with each individual hospital director and the director of the OR. I mean, it's not any more complicated than that. It doesn't need to be up here. We don't need to be hearing about it. It needs to be taken care of at the local level. And with that being said, how do you, I guess this question would go to Dr. Boyd, is how do you evaluate the performance of a director who's responsible, for instance, for the VA Washington Medical Center? I've heard about it since the VA Medical Center in Washington, D.C., since I've been here for 10 years.
So great question, and actually that goes back to one of my earlier comments. Absolutely agree with Dr. Day. We really need to push rights and responsibilities and authorities down to the lowest level possible, and in this case, it is at the front line. That's where we take care of our veterans every day. And really to the meat of your question, this year we have in a validation a timeline right now. We're looking at what would be those 4 metrics that would be conversation starters. In other words, it would be a high-level way for us to get a kind of a sniff test that maybe this medical center is not up to snuff with regards to their SPS working. So we have 4 metrics in prototype that we're looking at to validate to see if, in fact, it's what we need. We, in my office, we will be using that with our network directors, first of all, not solely, but communicating to them about their medical centers as well. But then we'll be using that hope with each medical center as well. And it will allow us to become, over time, a more predictive model, we hope, a more reliable tool to determine if there are some early warning signs of something going astray. So this is the administrative sale metrics for SPS, and we look forward to coming back and letting you know how that's working. But we really do need that model and that
Well, I think
conversation
it's
with
pretty simple. I mean, if you've got a hospital that can't get, with the funding we put out there, and as Mr. Peters said, if are there needs out there we need to know about, it. We'll provide those resources. But I think if you don't, you've got to replace your medical center director. I mean, that's so simple and basic that it doesn't need to go to a VISN or central office. You need to get to, that person needs to do something else. They need to be in a different line of work if they can't get that done. Mr. Chairman, I've hoped that this is the last we have to hear about this. I hope this is fixed. And, you know, it was one of the things, I have never had an operation in my life, and I had 2 major ones done on me in the last 2 years. And it never dawned on me that I have to worry about whether the equipment was sterile. That was the least of my worries. That should be the least of any patient's worries. I yield back.
Thank you. Dr. Boyd, we were told at our May 22nd hearing on VISN restructuring that VA would complete its VISN reorganization plan by July 1st. It's now early in September. That would be the 5th. And GAO's report highlights more shortcomings in VHA's governance structure. What is the status of the VA's efforts to reform the VISNs, and when will we be given the plan?
So we have mentioned VHA governance restructuring and the discussion about VISNs. With our new secretary now on board, I do believe, I know he was briefed just very recently in the past few days about the work to date. And so we are awaiting his discussion and his feedback, his recommendations to move forward.
Okay, can you give me a date when we might, will receive this information? I mean, or can you provide any insight into the changes that Secretary Wilkie could potentially be considering?
I wish I could, but I do not have any knowledge of that.
Okay. Well, do you get a chance to meet with Secretary Wilkie?
I have yet to have a one-on-one meeting with him, sir. I do meet with our executive in charge, Dr. Rich Stone, at the VHA level.
Well, maybe we could facilitate a one-on-one for you, because then you can pass along to Secretary Wilkie. And we've talked about this, the urgency or lack of urgency within the, if you will, the bureaucracy to get to an end game, which we all agree we have to get to sooner rather than later. Because if you reduce infections, you increase the quality of care and the recovery and reduce the overall cost. So it's a win-win for us to tackle, and the case is us, you, VA, and when I include the us, I could potentially be that patient on your table, and I want to make sure, as Dr. Rowe said, I don't have to think about, are the instruments clean? If you don't assume the mission and take control of it and take responsibility for it, we're going to be having hearings like this again. We don't want that. We have identified the problem. That is, there's no wondering what the problem is. The question is how and how quickly do we move forward with logical solutions? So the ball's in your court, and we need, as in we, all of the veterans and all of the families of veterans need a response to solving the problem, okay? And as Dr. Rowe said, if a medical center director, they shouldn't have to go to the VISN to ask permission or whatever it is to run their own backyard, their own operation. So anyway, having said that, I'd like to thank all of you for your testimony today. Before I close, I'd like to point out that today was the first time that Ms. Silas testified before Congress. Is that true? Yes. First time, okay.
Was it great?
Yeah, you look forward to coming back, right? Okay. Yeah, but you did an excellent job of representing GAO, and I'm sure you will be asked, if not dragged, to come back here, at some point, in the future. But with that, the panel is now excused. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Without objection, so ordered. I once again would like to thank all of our witnesses and the audience members for joining us here this morning, and the hearing is now adjourned.